welcome everyone here in person, and then we have a big group online today. It is my pleasure to announce our speaker for our IGN Seminar this week. We have Dr. Parmi Suchdev, who is a physician epidemiologist specializing in global health with a primary focus on maternal and child nutrition and health equity. And he has more than 20 years of experience spanning nutrition-focused public health research, global health education, pediatric clinical care, and program management. He's a professor of pediatrics and global health at Emory University and pediatric hospitalist at Children's Healthcare of Atlanta. He also recently, for several years, served as the lead epidemiologist for the CDC Central America office in Guatemala, where he worked to address public health challenges impacting vulnerable communities. And his research explores intersection of micronutrient malnutrition and infectious disease, with a focus on improving nutrition assessment, refining biomarker interpretation, and informing global nutrition policies. So, Parmi, thanks so much for joining us. We're really excited to hear about some of your recent work, and I will turn it over to you.
Thanks so much, Raina. And yeah, thanks to you and Sonia for the invitation to join this illustrious group. See a lot of familiar faces. So my task is to talk to you a little bit about an ongoing study on assessing the role of micronutrient malnutrition on pregnancy outcomes and under-5 mortality. We're about 3/4 of the way done. So our ulterior motive was to get feedback from you. So on additional analyses, because none of this work has been published as yet. So we'll try to get through these pretty quickly and hopefully have some engaging discussion. Let's see if my screen will advance. And yeah, so just want to start off with acknowledging our incredible team. Global health is team science, as you all know, and we're really lucky to have a really strong mix of clinicians, laboratorians, pathologists, epidemiologists, policymakers, the community members, and also want to acknowledge several folks from UC Davis, Christine Stewart, Ken Brown, and others who have really collaborated with us. We have a technical advisory group, and both of them serve on that. So with that, let's jump in. I have no relevant disclosures. This work was funded from the Gates Foundation, and I was formerly with the U.S. government, but no longer. So my objectives are to talk about, first of all, some of our gaps in understanding the role of malnutrition and child mortality. Talk about the design of the study. It's called CHAMPS, assessing the role of malnutrition and child mortality, and then give you some initial findings from the two arms of the study. One was looking at under-5 mortality, and the other one looking in pregnancy. And then, like I said, make sure leaving some time for discussion, questions. So I want to start off with the clinical case. This is a case of a child. 11-month-old. He presented in Kenya with a 3-day history of cough, refusal to eat, fever. He was actually admitted inpatient and was quite sick. He was drowsy, had respiratory distress, retractions. So he started on IV antibiotics, nutritional formula, got a blood transfusion, but unfortunately TJ died in less than 24 hours. So in the postmortem setting, some anthropometrics were drawn, and he was severely underweight. His weight for height Z-score was also low. Rapid testing for HIV, malaria, and TB were negative, but his blood culture eventually showed Klebsiella pneumonia, and he actually had some gram-negative bacteremia in his lung tissue too. So just want to think yourself in as being the pediatrician or the clinician in this setting, and how would you fill out the death certificate? So and you can take a hand for those in the room or virtual hand. So how many would you say, like, he died of malnutrition versus how many would say he died of bacteremia from Klebsiella? And then if he died of malnutrition, would you say that was the immediate cause of death, the underlying cause of death, or it contributed to his death, but it really wasn't in the causal pathway? This was all infectious diseases, and he just happened to be malnourished. So I think this is this raises a challenge. And this kid actually was malnutrition was not in his death certificate. And when I kind of came into this project, would see more and more cases like this. And as someone who works in nutrition, you have to ask yourself, would this child even have developed bacteremia if he wasn't malnourished? And if he had, he might have recovered from the antibiotics were he not malnourished. So clearly there's a role, but then, how do we better interplay this? So that really leads to the opportunity of CHAMPS. And CHAMPS is called the Child Health and Mortality Prevention Surveillance Network. It's now in its 11th year. There are 22 surveillance sites in 9 countries in sub-Saharan Africa and South Asia. And really the goal of CHAMPS is to better understand the etiology of child mortality, because if you want to prevent child deaths, we need to better untangle the causes. And given that there's very limited data from verbal autopsies and other data on etiology. And so what CHAMPS really does then is, when a child dies, whether it's in a community or in a hospital, there's a long consent and community mobilization process. They're enrolled, and then a minimally invasive tissue sampling is collected, MITs, and that's kind of the innovation of CHAMPS. And with all these different tissues, you can then do some pretty sophisticated diagnostics, especially on the infectious disease side, to figure out what's causing deaths. And 9,000 stillbirths and child deaths have been investigated since 2016. So I'm going to try to show you a video. I've never really done that on Zoom, so we'll see. If it doesn't work, we'll move on. But share soon. Can you guys hear that or see that?
Mortality remains one of the world's greatest challenges. Too many lives are lost.
Thumbs up or anything if you guys are seeing that.
We see it. I think I need to turn the volume up here.
Oh, okay. So this virtual people can see it. That's good.
Lack the information needed for best results. But what if we could change that? In 2015, Child Health and Mortality Prevention Surveillance, CHAMPS, launched with a bold vision to create a world where evidence-based interventions offer every child an equal chance to thrive. With funding from the Gates Foundation, CHAMPS scientists introduced an innovative approach to investigating causes of stillbirths and child deaths in high mortality areas in Africa and South Asia. The high-quality information generated would enable policymakers and healthcare leaders to enact changes and make this vision come alive. At the heart of CHAMPS is rigorous science. When a child dies, and with the family's consent, CHAMPS teams collect small amounts of tissues through a process called minimally invasive tissue sampling, or MITS. These samples undergo a series of advanced diagnostic tests. CHAMPS teams listen to each family's story and review medical records. All the data are reviewed by a panel of local experts to determine causes of death. CHAMPS doesn't just document deaths. CHAMPS investigates what happened to each child. Through better understanding, deaths can be prevented. Building trust in the community is the foundation of CHAMPS. CHAMPS teams work with community leaders to understand how best to engage in a culturally appropriate and sensitive way with families who have suffered a stillbirth or the loss of a young child. Our teams ensure our findings provide the answers that families, community leaders, and healthcare providers have been waiting for. This information is used to improve health. Since its founding, CHAMPS has grown from a pioneering idea to a global surveillance network. Now in its 10th year of operation, CHAMPS has examined over 8,500 deaths in 9 countries in South Asia and Africa. CHAMPS has uncovered a higher than expected burden of deaths from HIV and from bacteria that are resistant to most antibiotics. The data show that serious infections like pneumonia, sepsis, meningitis, and diarrhea continue to harm far too many children, especially those who suffer from malnutrition. And CHAMPS findings highlight the ongoing and urgent need for better prenatal and delivery care, which would allow many more families to have healthy babies and healthy mothers. Importantly, CHAMPS' careful investigations show that 4 of every 5 deaths are preventable with medicines and interventions that are now available. CHAMPS provides timely, accurate data to those who can act. Our findings bring families closure, highlight key health practices for communities, and show healthcare providers how to improve their practices. On a larger scale, the findings can strengthen health systems, guide policy and resource allocation, and lead to new products like vaccines. We've shown that when science, policy, and action align, lives can be saved. As we mark a decade of learning and impact, we look ahead to a future guided by innovation. CHAMPS will continue to expand its reach through partnerships and data sharing, so country leaders and global partners can act together to reach sustainable development goals. CHAMPS teams around the globe will continue to pursue excellence in our work, because every child deserves a chance to thrive. From unanswered questions to informed actions, CHAMPS is supporting the child survival agenda. We are just getting started. Join us in writing the next chapter of maternal and child health. Together, we are CHAMPS. Together, we can save lives.
All right. Well, hopefully that was a better overview than I could give on CHAMPS. And this video was done as part of a 10-year celebration of CHAMPS. So let me go back to you. Okay, so let's move then towards kind of the goal of this talk in terms of the role of malnutrition in this larger project. And I will start off with this graph because this is what drew me into working in nutrition in the first place when I was just finishing up pediatric residency and really had learned more about infectious diseases and was shocked to learn that about 1/2 of child death was due to malnutrition. But as we know, there are a lot of gaps in how these estimates have been developed. First of all, is how do you measure malnutrition? Is this based on anthropometry? Is this based on micronutrients? How is malnutrition defined? And then even once you've determined a child is malnourished, how do you assign it in the cause of death? And I think that example of TJ, shows that it is an underlying, and because we know there's this vicious cycle between infection and malnutrition. And so, where 60-70% of all children in these settings are dying of an infectious disease or have an infectious disease at the time of death, it's hard to know that did the malnutrition underlie this and made the child more susceptible to having an infection, or did the malnutrition result from an infection? And this continues to be a challenge in terms of interpreting our data. And then I think those of us who work in the micronutrient space will really resonate with the idea. Unless you look for micronutrient deficiencies, you're not going to find them because they often don't present themselves clinically. And so really what excited me with CHAMPS was this really unique opportunity to measure gold standard micronutrients, such as vitamin A that are stored in the liver, other micronutrients that we normally couldn't do in living populations, to more definitively look at what is the burden of malnutrition in these settings, but then also what is that? Could micronutrient malnutrition actually play a role in the cause of death? So let's go through some of these gaps then. So first of all, how do you measure anthropometry? And actually took some tours of our own morgue and here in Atlanta, visited some other morgues, and often pathologists will rely on the clinical record, the last known weight and height and the record. And as we know, even in resource-rich settings, that's often poorly done. And if measurements are taken in the morgue, they're often using like a paper tape, and so we're finding in CHAMPS a lot of our data had pretty poor quality. So the first thing we did was, can we use a standard anthropometry in a postmortem setting? So using wooden boards, calibrated scales, and then we even tested using this 3D novel tool. And long story short, the 3D tool had a lot of issues. And yes, you could do standard anthropometry. Yes, there was rigor mortis, but with some constant pressure, the measurements could be done really well. And in a sense, the measurements were actually even higher quality. If any of you had tried to measure a toddler, right, that's screaming and kicking, that's not the case in this setting. And so that was the first step, showing that these measurements were doable, and then implementing training into all our sites so that anthropometric measurements could be done better. The next challenge is, okay, now that you have postmortem anthropometry, then how do you assign it as a cause of death? And this graph on the side kind of shows the how WHO assigns cause of death. So you have part one, which are in the causal pathway. So you have the immediate cause, and then you have underlying causes, and then you have part two, which might not be considered in the causal chain, but they were related to the cause of death. And this is a bit of a subjective process. So there are these decode committees. Any of you who are clinicians and have been in M&M reports. So it's essentially pathologists, clinicians, community workers, and they review all this data and then come up with this sequence of deaths. And so when our review of all the CHAMPS deaths, this was about 3 years ago. So I think about 6,000 deaths at that time. Malnutrition was put in the causal chain, so in part one and 40% of deaths. But what we found was that a much larger proportion of children were malnourished, severely wasted, stunted, underweight, based on postmortem anthropometry, 75%. So part of it is like trying to understand this gap and coming up with a more systematic approach so that the decode committees see the data on the anthropometrics and can then decide where to put it in the causal pathway. The other gap is that we started to address was the role of micronutrient malnutrition, which I talked about before. And this was a pilot study done in Kenya and South Africa, looking at liver samples, and the livers were sent to Sherry Tanamajarlo's lab at University of Wisconsin for retinol, which is the gold standard measure of vitamin A. And really, this was a feasibility evaluation just to see, could we get enough liver tissue? Could we produce retinol values? And really what we found was actually a bit shocking. There was really a histogram of distributions. There was concurrent vitamin A deficiency, but then also some signs of excess in both Kenya and South Africa. And then we showed that vitamin A deficiency in boys, not girls, was associated with the increased risk of infectious mortality. So this was kind of a first sign that made us realize we should probably look at this more systematically. So that led to the launch of the ARM-CHAMP study, and we're in our third year. We've had some delays. We were supposed to be done by now, partially due to the government shutdown, and the study has relied on the CDC for a lot of things, but mainly as its biorepository. So all these specimens, a lot of the pathology and diagnostics are done in country when possible, but the biorepository is at the CDC. And so we had to leverage that biorepository to then go collect those liver and serum and other specimens to send them out to labs. So that's what led to a lot of our delays. But basically, this ARM-CHAMP study is divided into two aims or two arms. The first is on the children who have already died and assessing anemia and micronutrient biomarkers, and then looking at its association with child mortality. A limitation in CHAMPS is we don't have a control group. We don't have living children or sick children who we have liver biopsies. So we only have children who are died. So we've essentially set up a case control design looking at infectious causes versus non-infectious causes. And with the limitation that then again, these kids were all severely ill, but we do have a proportion of kids who maybe died of an accident, died of poisoning, and that can be our comparison. And then those are the list of indicators that we're measuring, a series of micronutrients, both in serum and in the liver. We're also measuring hemoglobin. And then the second aim, very different. But as those of us who work in nutrition know, you can't look at early childhood nutrition without understanding what's happening upstream with the mom, and especially in settings where we would expect malnutrition to be across the life course, and so this was actually, I thought, would be the hardest part of CHAMPS, because pregnancy surveillance did not include any biomarkers, and so we had to really start the study from scratch in terms of training teams to collect blood and get consent. End of the day, this actually ended up being kind of the easiest arm, and I think one of the findings, I'll talk about findings, but one just to tell you off the onset, was that actually introducing micronutrients anemia screening actually incentivized women to present to ANC earlier. So we had more women presenting in first trimester, and we had like 95+% women who stayed through the end. And then the indicators are listed here. Again, a broad list of indicators, both to understand nutritional status overall, but also looking at etiology of anemia. That was one of our other goals. So this is like a map, a slide we presented to Bill Gates during a learning session last fall, which essentially shows one of the challenges of doing a study like this. And I'm sure you could produce similar graphs or analyses with your own work. When you're trying to measure micronutrients, there isn't a one-stop shop to get all these micronutrients measured. It requires multiple international labs, and we really wanted to pick the labs that were accredited by CDC, that had high quality, and so we didn't really necessarily look at cost and carbon footprint. So at the end of the day, it resulted in us sending using 8 different laboratories in 6 countries, and you can see where these specimens had to travel. And I did some just costing right before this, and the testing itself was about $220 an individual, whether it's a child or a pregnant woman, and then an additional $50 just to ship the sample. So I think that's a challenge. We need better biomarkers for sure, and I would love to get your thoughts at the end on how we can get to there. So just some preliminary results first for AIM-1, and then we'll move on to AIM-2. So for AIM-1, we have preliminary results. We all have 800 MITS cases. All the specimens have been sent, and we have some preliminary results on B12, folate, retinol, and both in the serum and the liver. And of these 800 kids, this is their kind of demographic characteristics. So as you might expect, most of the deaths are happening early, and so they're in neonates and deaths in the first 24 hours, and we have a much smaller proportion of deaths that are happening in infants and children as expected. And then overall, 82% are in facilities. As I mentioned before, a majority had infection in the causal chain, and then looking at postmortem anthropometry, nearly 80% had indications of stunting, wasting, or underweight. So in terms of all the data points that goes to these decode panels that I'd already described, I just wanted to put this all in one place. So they have a demographics, clinical abstraction, the data that comes from the MITS in terms of the pathology, also a different point of care testing, and then really what we were doing is adding both hemoglobin and micronutrients to this portfolio of other pieces of information coming in. So one of the first things to really report out, which I think is important, is just the feasibility question. Can you use postmortem tissues to measure micronutrients? Because not many people have really tried to do this. A lot of animal studies, but not a lot in human studies. So I think the answer is it's mixed. For liver, yes, the retinols retained well, and it was easy to get a sample. Some of the ones that require blood were a little more challenging, especially you can see for serum retinol and serum folate, both because of the volume of blood that's drawn, and then obviously the hemolysis. I mean, it's almost universal hemolysis. Most deaths are the MITS takes place. They all take place within 24 hours. Most are within 8 hours. So it actually they do a really good job. And then the blood's drawn either from a subclavian femoral artery or sometimes directly from the heart. So can get a pretty good volume of blood. It's just a question of is there some hemolysis that's already taking place. So again, it varied in terms of are we able to produce a lab result that we can trust? It depended on the biomarker. So in terms of hemoglobin, this was something we also wanted to look at anemia. I mean, again, anemia is not solely a nutritional issue, but we know anemia and severe anemia in particular are directly linked to child mortality. And we weren't measuring hemoglobin in CHAMPS, partially because there isn't really good data to show that can you if you don't have an antemortem hemoglobin, can you measure it postmortem? So the first thing we did was just do a study where children in South Africa were dying in a hospital, so they all had a CBC before they died, and so we were able to compare that CBC antemortem to a postmortem HemoQ, and then we used different sources of blood, dry blood spots, whole blood directly collected, and the long story short is that there was differences, but it was a systematic, not random error. And basically, there's a systematic drop in hemoglobin, as you might expect, due to volume shifts and hemolysis postmortem. And so we found that by applying this fixed correction factor of 2.5 grams per deciliter, we could reliably estimate hemoglobin at the time of death. So after this pilot in South Africa, we then implemented hemoglobin testing using HemaQ in all our sites. And so this is the results we found so far. This is just the initial 316. And these are the thresholds we're using to define anemia. Because as you know, WHO doesn't have thresholds below 6 months, so we had to use some more clinical references. But as you might expect, there was a lot of anemia, and it really seemed to increase with age, which also is probably not surprising due to what we know of how anemia develops. And then really what was, I think, more important was the burden of severe anemia. And that too was pretty rare in 0 to 1 month olds, but that increased. And so overall, about 20% of children had severe anemia. But what was, I think, the most interesting is despite anemia and severe anemia being common, the decode panels only identified about 9% of these cases where anemia was listed as a cause of death. So there's, again, this gap we're seeing. So next steps are to determine the etiology of this anemia, to kind of work with the decode panels more to kind of disentangle. And I think anemia is very similar to malnutrition. Did the severe malaria cause anemia? Did the sepsis cause anemia? Was anemia there and led to the illness too? I think that's a challenge with anemia. So the next thing I want to show out of AIM-1, which I think is probably, to me, one of the most interesting findings of this whole talk, I'd love to get your thoughts, is on vitamin A. And again, I'd mentioned the pilot work in Ethiopia and Kenya. So now we're looking at data from 4 countries on vitamin A deficiency and excess using retinol from the liver. And so the red shows deficiency. And so the first striking thing is all 4 of these countries, there's severe vitamin A deficiency. You know, the WHO threshold is over 20%. And I mean, in Kenya, almost all the kids were vitamin A deficient. But we're seeing this issue in South Africa where you're seeing kids who have higher hypervitaminasis. And these are the thresholds we use. I know there's some controversy on how do you define hypervitaminasis in A, but this is a conservative estimate. And then we see this age pattern where really the excess is happening in older kids. And so the question is, where is this vitamin A coming from? I mean, there are 2 questions. One is okay, so what if your serum retinol is high or your liver retinol is high? Does this cause any liver damage? And the second issue is where the vitamin A coming from. And I think our hypothesis is that this is coming from vitamin A supplementation. And we know in places like South Africa, the vitamin A supplementation is still 90+% given, but then there are also a lot of other sources of vitamin A from the diet, from fortified foods. And then the pathology side, I think, is super interesting. This is some work not from CHAMPS. This is from a study in Guatemala City where they've had universal sugar fortification vitamin A for quite some time, and this was adolescents and adults, and basically as you see an increase in liver vitamin A concentrations, you start seeing signs of hepatic stellate cell hyperplasia that are suggestive of liver damage due to hypervitaminasis A. And so we've started looking at this in our CHAMPS study. And we've reviewed so far just about 10 cases, and actually all 10 of the cases had signs of stellate cell hypertrophy. But we want to do this more systematically, so we're doing essentially a nested case control study where we're matching cases who have hypervitaminasis, which are those who don't, and then also stratifying by the cause of death, because some of these liver changes can be not just due to vitamin A toxicity, but also due to sepsis, metabolic changes, and then basically using immunohistochemistry to do several stains for inflammatory markers and basically produce these images like this. So this is all, we just ordered the reagents yesterday. So and then the other thing we're going to do is really to better understand the vitamin A exposures in South Africa, just anecdotally, and I'd love to get your thoughts, but anecdotally, we've heard from a lot of the clinicians there that vitamin A is given out essentially like a vitamin. So if a child comes in with an acute respiratory infection, they're given vitamin A. So measles, other things. So a child in a given year could have 3, 4, 5 doses of vitamin A, which is above what is done for a preventative purpose. So we want to capture this into child clinics, not the deaths, but to try to capture what are the practices of vitamin A delivery in that setting. All right, so let's move now to AIM-2. I guess I'll save the end for questions, but if you have questions along the way too, please feel free to put them in the chat. I know I'm presenting a lot of things pretty fast. So that was the micronutrients and child mortality. So now we'll move on to pregnancy. And this is a bit of a more complicated design in the sense that we wanted to capture nutrition, of course, across trimesters. So our goal was to enroll women in the first trimester, as many as we could, but we set the limit at second trimester. So our goal was to get 300 in the first and then 1,000. We actually did a little bit better than that, but essentially 1,000 women in both Kenya and Ethiopia. We did it in only these two countries because this was a pilot. And then you can see the testing that was done at each visit, including dietary intake, and then a series of laboratory tests. Just to give you a sense of the health characteristics of the Ethiopian and Kenyan women, so some pretty stark differences in terms of HIV prevalence, much more a problem in Kenya than Ethiopia. And then on the flip side, Ethiopia has a much larger burden of malnutrition. A really high prevalence of these women had really low MUAX at enrollment. In terms of the outcomes, in terms of adverse pregnancy and birth outcomes, so things like low birth weight, these are the prevalences. We still haven't done the analyses linking these to our different exposures, but we should be able to because these outcomes were seen, and we weren't powered to look at some of these more rare outcomes such as mortality. It was more to look at the micronutrient concentrations, but so we'll have to see how these analyses can pan out. So in terms of some other results, dietary intake, and I see Christine's online and her PhD student Lydia, as well as another PhD student in Ethiopia, have led a lot of these analyses, and I think this was again a unique opportunity to when you're measuring biomarkers to also bring into diet. And so this was a sub-study of 200 women in both Kenya and Ethiopia that had both dietary quality and usual intake measured. And I'll just show you some initial results from the Global Diet Quality Score. And essentially that just puts categories of foods into the healthy food groups, unhealthy food groups, and then ones that are conditional. And the score essentially you want to have it the higher the better. And the first thing you can see is that overall diet was below this 23 cutoff. Really in both sides. So there's definitely an opportunity for improving nutrient intake. And then the other conclusion from this is that there really wasn't a lot of variation by trimester. And we also panned the study across seasons to look at to make sure we were accounting for seasonality. So not a whole lot of differences, I guess, across both trimesters, but across country in this analysis. Also looked at some problem food groups, and so there are a little bit differences here in that there's a high consumption of refined grains and white roots and tubers in Ethiopia versus both grains and more sweets and ice cream in Kenya. So again, a lot more to be done on the dietary intake, but this is just a snapshot of what's potential. So now into some of the biomarker work from pregnancy. And this was probably not surprising. This is very consistent with what other studies have shown in terms of anemia being common on the left, and then iron deficiency also being common. And what we're also seeing is that, and the bottom is the first trimester and then up to third trimester. So anemia becomes more common as the pregnancy progresses. And some really high rates, especially in Kenya, where 2 out of 3 women were anemic by the time they were in the third trimester. And we're still waiting for some iron results from Ethiopia for that third trimester, but the overall pattern is that iron deficiency follows the anemia pattern, where you get more iron deficient as pregnancy progresses. And these are both settings where there's supposed to be universal IFA as part of ANC, and we captured that as well. Haven't done all those analyses, and actually both countries are moving to MMS too, as most countries are, as everyone knows. The one good story, I guess, was looking at urinary iodine, and both these countries have universal salt iodization, and really both the countries were performing well in terms of urinary iodine in pregnant women. Probably one of the more troubling findings, in addition to that vitamin A in children, I think the most troubling in pregnant women is the story of folate, especially in Ethiopia. So we looked at both serum folate and RBC folate. So serum being a more short-term measure, and RBC a more long-term. And RBC is the indicator recommended to look at risk of NTDs. And it's shocking if you just look at the RBC folate side of things. 68, 71% of pregnant women in Ethiopia have RBC folate deficiency and increased risk of NTDs. And this is consistent with their Ethiopia National Micronutrient Survey, which didn't look at pregnant women, but non-pregnant women of reproductive age, and the numbers look identical. So this is happening obviously pre-pregnancy, and so despite use of or potential use of iron folic acid, it's going to be too late, right, to prevent the NTD. And this is confirmed in what we're seeing in CHAMPS in terms of babies born with neural tube defects. And so this was an analysis looking at NTDs across the whole CHAMPS network, and Ethiopia was really an outlier. I don't know if you can see this forest plot, but they're like way over here where the adjusted mortality fraction is 7.5. So they've had almost 200 NTDs born, represents 10% of all deaths in Ethiopia. And then if you kind of look at the mortality rate due to NTDs, it's 104 per 10,000. So really high. And this is a graph that compares countries that shows the same mortality rate per 10,000, right? So here's 104, but it shows pre and post fortification. And this is really the message, to the students and the audience that this is why we do, fortification of staple foods, most often wheat flour, but other foods can be fortified. And uniformly in all these countries, once you implement fortification, you see this drop of an NTDs. And so Ethiopia today is at this 104. And so they have a lot of room to move. And just a couple of weeks ago, exciting news, a trial was done looking at double fortified salt, adding not just iodine, but folic acid to salt. And then in a clinical trial has been shown to improve folic acid. So the government's going to be rolling out double fortified salt in the upcoming months. And so part of our role in CHAMPS is going to be to do the M&E on this, along with Nutrition International, EPHI, and other partners, because CHAMPS is already doing the surveillance for these NTDs, and can also look at looking at folic acid in women of reproductive age, both pregnant and non-pregnant. And then another piece is when a child is born with an NTD, really follow those kids and see what their developmental and other outcomes are. So that's part of the triple surveillance we say for when you introduce fortification. Okay, last couple of minutes. So what have you learned? There's a lot of data presented. So for anyone, we've learned that malnutrition is really common based on postmortem anthropometry. 75% of deaths have malnutrition. While biomarker testing can be challenging, it's feasible for most of the micronutrients. And anemia, although being super common, it's rarely assigned as a cause of death. And then we've shown severe vitamin A deficiency is prevalent, but there's signals of excess in some settings that really warrants some more attention. And then on the pregnancy side, I think really what's exciting is that ANC is a powerful platform for nutrition monitoring. Could this be a way, with the loss of DHS and some of these other ways of getting nutrition data, can we use ANC, healthy pregnant women as a platform? I think in this small microcosm of a study in 2 countries, we've shown that it can be. And then anemia and iron deficiency worsen across trimesters, and really the story of severe folate deficiency in Ethiopia supports urgent fortification. And really now it's about these initial research findings, moving them into policy. I think we have some examples with the Ethiopia and the fortification. And to me, one of the big findings from this work, nutrition is often a forgotten topic in surveillance. I think those of us who work in nutrition would probably agree. And when I worked in Guatemala the last few years, we really focused on infectious diseases. It there was a bit of a disconnect. And when you talk to the policymakers and the ministers of health, they're like, yeah, chronic disease and nutrition is really our leading burden. So I think we need to have more opportunities like this where we integrate. So when we think about effective surveillance, we're not just thinking about surveillance for, vector-borne diseases, infectious diseases, nutrition. We're really integrating them. So I think that's one of my take homes for you all. In terms of our next steps, where do we go? Like I said, we're still doing some analyses. We have a supplement plan for the American Journal of Clinical Nutrition that we hope to submit this summer. And then we're in discussions about doing a CHAMPS 2.0. So in our remaining time, I'd love to get your thoughts in terms of what are the gaps you see in the work we've done, and how could these gaps be addressed with the next phase of the study? A few I've listed here. I think this issue of not having a control group. So could we have like a cohort of children who are severely ill but not that haven't passed, where we could actually measure some of these biomarkers, address this reverse causality issue, and also validate some of the results where just because you can measure a folate, a folate postmortem, how do you interpret that? I think that's another challenge, and we have yet to get all the data, but I'll probably be reaching out to some of you guys too on help on how to validate some of these things, because we've never really looked at a folate in a 2-day-old, right? Who died. I think there's a lot of opportunity to line a lot of pregnancy cohorts. Many of you have been involved with across the world, that I think there needs to be some more cohesion in these pregnancy cohorts, to look at some of these issues of trimester-specific micronutrient cutoffs. Like WHO's changed the anemia cutoffs, but the micronutrient cutoffs I think likely need to be trimester-specific too, especially accounting for issues of plasma volume. And then I think there's a big push to come up with multiplex platforms. I think I showed you that in that slide, the cost of sending all these specimens around the world. So there's platforms like Quantus, but there are others coming out where then the testing could be done in country, and not require this large carbon footprint. Yeah, so I guess my last question to you guys is what do you think would strengthen the next phase of this work? So I think that's all I had. Thanks.
Thank you so much. Great. Yeah, thank you. I'm trying to fix our technology on this side, but we definitely have some time for some questions and discussion. I want to make sure we can see if we have hands up from those are online too. While people are thinking, I just want to say congratulations on doing these studies, because I think this is so challenging to do, but it's such important data. So this is really exciting to see. I see Kay has her hand up, so go ahead, Kay.
Yeah, well, thank you so much. That was a wonderful presentation. And my question actually has to do with, in the conclusion, you, I think, said that about 75% of the mortality cases involve some sort of anthropometric deficit. And I'm just wondering if that needs to be set against what the prevalence is in those who didn't die, or because in these populations, prevalence of those anthropometric deficits is probably quite high. So in other words, what is the excess that you're seeing in this group?
Yeah, thanks, Kay. And I think I think that's true for the anthropometrics. And I think you could even argue when we start looking at anemia, when we start looking at iron deficiency, probably a similar question. And so I think you have to remember, first of all, that these are the kids who didn't make it, right? These are the sickest of the sickest, and who ultimately died. So all these catchment areas, they do have some level of an HDSS, like a demographic surveillance, and so we do have some data, and different countries have different resources to what degree they've been able to measure it. So like Kenya, for example, has had some pretty good community level data, and it's high. So I'd say not 75% high, but 40-50% high. So I think what we're dealing with, and probably really all these sites. And again, the sites for CHAMPS were also picked based on where the mortality was the highest, because so you otherwise you'd be you couldn't really answer this question if you're not having kids die. It's a kind of a morbid thought. Yeah, so I think it's overall high, but without having an ongoing comparison, it's hard to know. So again, we still don't know did the malnutrition lead, well, what came first, right? And so I think that's a bit of the challenge with CHAMPS.
Thanks.
Christine, you have your hand up.
Sorry, trying to unmute myself. Thank you so much, Parmi. This was a great overview, and great to see these results again. We've been working on continue to work a lot on the dietary data analysis, and it would be great when we can put all these pieces together in the supplement. My kind of comment and question for us for thought about the point that you raised about using ANC as a platform for surveillance. And I think that, what CHAMPS is showing is that it is a mechanism to potentially collect a lot more data, and that if the information can be fed back to the women themselves, it's also an incentive to them to be coming in for ANC visits, perhaps earlier or more frequently. However, I am a little bit cautious, though, about using that data as our primary source of information on nutrition and health among pregnant women, because there still is going to be a fraction. The fraction is going to vary by country and location and whatnot, but a fraction of women who do not come for ANC. And we know that in a lot of cases, the people who are not coming in for care are the worst off cases, right? And so the kind of information that we might get from ANC surveillance might be a rosier picture of the health situation than if we are doing representative sampling. And so I think that, kind of going forward there continue to be challenges with DHS or other, large scale population surveys, doing some kind of benchmarking, I guess, to understand how representative like ANC or other clinical sampling populations are in relation to the general population would also be really important for us to know how biased those samples might be.
No, I agree completely. I would love to hear from others who have maybe thought about this also, and I think it's not even ANC. I mean, I think their thoughts of using other clinics, even hospital data. I was in India, and they're even considering using kind of their private lab network. So basically, anyone who goes to a private lab, and now you have if you look for data, you can find it. But now you're talking about like who's going to a private lab in India and getting testing. And again, it could be a useful piece, but yeah, like how do you interpret that? Yeah, so no, I think it's a good question. I know Tanzania is exploring this. They have a very integrated lab system, and I mean, I think the representative is a good question. I guess for me, it's like if you're going to go through the effort, if whether you're a clinician or a public health practitioner to take someone's blood, like is that an opportunity to look at nutrition, especially if you had a point of care or multiplex platform, then I think we'd be getting just data from a lot of inputs. Yeah, the interpretation piece, I think we're going to need some really good epidemiologists, statisticians to, like you said, triangulate and make sure we're benchmarking it and not making like misinterpreting it, saying there's a super high burden because we looked at either a higher sick or lower sick population. Yeah.
I have a question, maybe a little bit along those lines. I was wondering if you could talk a little bit about how the CHAMPS, the surveillance sites were selected. And I was thinking especially about, I mean, I think the information on the micronutrient biomarkers among the children is really interesting. And you were talking about how you're thinking about getting at exposure assessment, especially for the vitamin A. So I was wondering if you could talk maybe about both of those, about how those sites were selected, and then what is the record keeping like in terms of their intake exposure, and just kind of ideas about what that might look like.
Yeah, so the sites themselves were, I mean, it's a long process, and then CHAMPS has recently enrolled 2 more sites and went through, maybe had like 8 or something apply and then landed on 2. So it's a combination of a lot of reasons, as you would think. You need to have some level of infrastructure where you have surveillance, and so you can quickly, rapidly identify the deaths. You need to have enough deaths so that it can move along, and then you obviously need to have good diagnostics, good like all that, at least at a baseline. I mean, there is a clinical abstraction. So based on how well that's done, I mean, everyone has their little health cards in some settings. So all that's brought in. Like the vaccine data is pretty good, but like I would have thought the vitamin A piece would have been great. So actually, we actually had both Kenya and South Africa look at all the liver specimens we had, and look at the clinical cards just to look at vitamin A, because often vitamin A is given with with vaccines, and I think it was like 10% even had it documented, and then among those that had it documented, it was like missing in most. So it was actually depressing. So I think we need to build. But again, it's like until you realize you need this. So now we're just gonna have to build that into the questions, where you could then get that information at the time of death too, and either ask the mom, try to find it, and more explicitly. Yeah.
Thanks. No, I think that says that there are a lot of challenges, but once you know that what those are, then you know what you have to
Go look for. Yeah.
solve. I think we're about at time, but I see we have one more question. Steve, go ahead.
Okay, thanks, Parvi. Excellent work. And just mine might be a CHAMPS, kind of 2.0 question, but what I see is kind of the merging of 2 bodies of evidence on the medical side as well as the nutrition side. And I'm wondering how kind of the nature of policy discussions is changing as you do that. On one hand, it could be broader. You're kind of setting nutrition policies alongside kind of medicine or provision of medicine policies. And how is this shaking out, and how are who's involved, and what's the nature of these kind of emerging and broader policy discussions thanks to your work?
Yeah, thanks for that question. And that's is exactly the question the Gates Foundation keeps asking, and that's their task. They've CHAMPS has gone 10 years, another 5 for now, and that's really the ask of the network is to move this into policy. So data to action, they call it. So there's a whole stream of work focused on that. It's not easy. I'm not a policy wonk, so I'm not great at that. But it is a priority, because and I think the loss would be all this data is collected, and it just sits there, right? And to me, as someone who works in nutrition, I think often the nutrition actions are separate, and this is all about preventable death, and I think everyone in this country and in these countries all say, like, yeah, we have so much malnutrition, but they're often their policies don't match that. They're focused on better detection of infectious diseases, bed nets, like you name it. So I think if anything, CHAMPS has shown that again, there needs to be an integrated strategy for health and development, and nutrition is an important piece of that. And I think there's a lot of excitement about the fortified salt in Ethiopia, and I think if that is shown to make an impact, that's going to be a big win for nutrition, and what kind of these type of activities can result.
Great. Well, I think we are at time, so we just want to thank you again for such a great presentation.